Hello, I'm Neal Shore from the United States, and I'm here to talk about what is new for newly diagnosed metastatic prostate cancer patients. I will be joined today for both a European and a US perspective by my colleagues Niraj Agarwal and Stephen Janyu. What is new? We have two provocative new findings that we can do so much better now for our patients with advanced prostate cancer, newly diagnosed, other than receiving androgen deprivation therapy as a monotherapy. So we'll hear about the combination trials of ADT with abiraterone and acetate, which have now followed on the provocative findings of chemohormonal therapy for the same patient population. We'll hear about the survival benefits. We'll hear about the safety and toxicity. We'll hear about access, cost, and ultimately, how do we make a decision which to choose? How do we combine or sequence? Are there specific subpopulations of patients who might do better with one versus another? And how do we monitor these patients? What will be the downstream implications once these patients are no longer androgen sensitive but become castration resistant? So it's a wonderful time to be treating these patients, whether you're a medical oncologist, a urologist, a radiation oncologist, a nuclear medicine radiologist. And so it's a great time to be doing the research and hearing also about the new clinical trials.
Hi, this is Niraj Agarwal at ESMO. Today I'm going to discuss or share with you some very exciting data which were presented in recent meetings and which have really changed the practice in men with hormone-sensitive metastatic prostate cancer. There were two trials which were presented recently and also published in New England Journal of Medicine. The first trial was the Latitude trial, and the second trial was the Stampede-G trial. In both these trials, patients with newly diagnosed hormone-sensitive metastatic prostate cancer were included, and they were randomized to standard androgen deprivation therapy or standard androgen deprivation therapy with abiraterone. There was a remarkable improvement in survival in patients who were treated with abiraterone. There was a 40% reduction in risk of death in patients who got treated with abiraterone upfront compared to those who did not. So as we know, these data came in the backdrop of very similar trials of docetaxel chemotherapy, which was given to these patient population or these men upfront in a very similar setting. Remarkably, the survival benefit and the reduction in the risk of death was very similar with docetaxel chemotherapy as well. So now we have two options to treat these patients with. So which option should we pick? Which is the better option? Answer is, we do not know until we have biomarkers to select one of these options. So unless or until we have biomarkers, we are going to be relying on several other patient or doctor-specific factors. For example, the copay of the oral drugs can be very high for some patients who cannot afford them. For these patients, the answer is very simple. They have to be treated with docetaxel chemotherapy. If there is no problem with affordability, then there are other factors which will come into the play, such as patient's preference, doctor's preference, other comorbid conditions, quality of life, and scheduling. So what is there for us in very near future? There are 4 or 5 new androgen axis inhibitors which are being tested in this patient population, either alone or in combinations. And we expect to see many of these drugs or combinations getting approved and be available in the clinic within the next 3 years. So how the practice is going to evolve with these newer drugs which are going to be available to us is going to be fascinating.
Hello, my name is Stephen Janyu and I'm a urologist from Leuven, Belgium. I'm here at ESMO 2017 and I'm I want to talk to you about very exciting new data that have just come out. The data relate to the treatment of hormone-sensitive metastatic prostate cancer. And as we know, there have been 2 studies who have been published 2 years ago and who have changed guidelines. These studies added docetaxel to standard of care, being ADT, in men with hormone-sensitive advanced and metastatic disease. And these 2 studies showed great benefit for these men, extending life with a year, and in some subgroups more than a year and a half, about a year and a half. Now, guidelines have immediately taken up this information and changed and proposed docetaxel-based treatment, docetaxel plus ADT, as a new standard. Now, very recently, 2 new studies have been presented and published, and they deal with a very similar, with a very similar disease, adding abiraterone to ADT. And abiraterone was given continuously during the duration of the trial. Now here, the survival benefit was at least, certainly at first read, very, very similar to the ones we've seen with docetaxel. And that's very exciting because now we have 2 options to provide to these patients. And I'm sure the guidelines will pick it up, this new information will pick it up very, very fast and will adapt and will add ABI plus ADT as a new standard of care next to docetaxel plus ADT. But we, as clinicians, we don't only have to, absorb the data and apply them, we have to think about patient profiles as well. And if you look very carefully to these studies, you will see that patients with oligometastatic disease or low volume disease and patients with high risk localized disease don't seem to benefit that much as patients with high volume hormone sensitive prostate cancer. So here, I think we have a job as clinicians to provide new data and to do new studies in exactly those patients and extend these patients' life equally significantly as those with high volume disease. And what could be done, in my opinion, as a urologist, I think we should intensify local treatment in those patients. But don't do that right now. We have to wait for ongoing studies and the results thereof, and probably also add in selected patients metastasis-directed treatment to the standard of care, then being ADT plus any of the 2, abiraterone or docetaxel. Randomized controlled trials are accruing as we speak. And I'm looking forward, and I hope you too, I'm looking forward very much to seeing the data of those trials in the upcoming events in the next couple of years.
So we've heard 2 excellent presentations with slightly different perspectives, medical oncologist, urologist. What's clear is this is a time for the treatment of patients with newly diagnosed advanced prostate cancer, certainly with high volume disease, where no longer can we only consider androgen deprivation therapy as monotherapy. We have to think about a discussion of chemohormonal as well as adding abiraterone acetate. The challenging questions are, which do I prefer? Which do I promote to my patient? What are the factors? And Dr. Agarwal did a very nice job of listing all of those factors. Dr. Junot said in his institution, he's concerned more about patients with low volume disease and high risk locally advanced disease. And where does the data of systemic therapy in combination with more aggressive approaches to an active interventional treatment, be it surgical or radiation, come into play? So these are very important areas for new investigations and trials. And so we have combining therapies. How do we sequence these therapies? What would be appropriate markers to look at in addition to the usual factors that we assess? Comorbidities, serological evaluations, logically PSA, albumin, hemoglobin, LDH. There are many other factors, genomic factors, which will also add to our decision making. And how will these new therapies affect our CRPC treatments? And can we do better in terms of patients upfront with a combining effect? So is it only ADT and taxane-based therapy, ADT and a novel oral anti-androgen? Do we sequence them? Do we combine them? We don't know. We need more data. And what about a third option that could be added on? Is it an anti-resorptive? Is it a targeted alpha therapy? Or another form of an oral androgen receptor antagonist? So, as we said in the beginning, it's a very good time for all of us who are dedicated to taking care of patients with advanced prostate cancer. We need to all be very vigilant regarding new data and new publications, and recognize that there are global variations, not just with accessibility and cost of medication, but sometimes in our philosophical perceptions as what would be best for our specific populations. Thank you for listening.